Welcome to our podcast on the female reproductive system. During this podcast, we're not only going to examine the female reproductive tract and identify the different regions and distinguish them histologically, but the majority of what we're going to do are going to be to compare and contrast the different stages of follicular development in the ovary itself. Then as we move down the fallopian tubes, the uterus, we'll look and identify the different layers, the functional layer of the uterus, the endometrium, and the myometrium, the muscular portion. So as we mentioned, the female reproductive tract includes the ovaries and then the reproductive pathway, the oviducts or fallopian tubes as they're referred, the uterus, the vagina, and then the external genitalia, which we're not going to go into a lot of detail about because that's primarily integument when we talk about external genitalia. But in our diagram, we can see the ovary, and representing different stages of follicular development in a corpus luteum that remains after ovulation. Here we see the beginning of the oviduct, the fallopian tube. The open end or the infundibulum is surrounded by these finger-like projections called fimbria, which we'll examine much more closely as we move along. Here we have the uterus, the thick wall uterus, the endometrium and the myometrium, the cervix, the opening or os of the cervix, and then the vaginal canal. We can see its location relative to the bladder in the pelvic portion of the body, and we'll also mention some of the ligaments, the round ligament, the broad ligaments, and how those sometimes impact comfort during pregnancy. So we begin with the ovaries. Now, these are paired structures located in the lower pelvis, and they are suspended within the uterus via the broad ligament. Now, this broad ligament is going to interconnect the ovaries with the uterus in this abdominal cavity. And as we look in the ovaries, if we cut this in cross section, we're going to see this outer germinal epithelium. It's really going to be a peritoneum, and it's different than what we've seen with peritoneum before. It's not going to be squamous in nature, but more cuboid in its shape. Beneath that is going to be our tunica albuginea. Now, this is also going to be a term that we're going to use with male reproductive system, but this refers to this dense, irregular connective tissue capsule that's just beneath our germinal epithelium that we have. Then, like most of the other organs we've examined, we will have a cortex and a medulla, although these are not going to be readily identifiable as such present in the ovary, but more the components of these different locational terms are going to be distinct as we look at our follicular development. So in the cortex, or this outer portion of the ovary, we are going to have a number of stromal cells that are interwoven between our ovarian follicles. Now, these follicles are going to consist of primarily an oogonia. This is a primordial germ cell. And they're going to be surrounded by follicular cells, and these cells, as they develop will change their name slightly. But we're going to stick with oogonia first, and typically there are 1 million or so oogonia that are incorporated into the ovaries as follicles. Now, by the time a woman reaches menarche, which is menopause, only 400,000 or so remain. Now, you may think, wow, 600,000 have been ovulated and could be fertilized, and that is absolutely not the case. Because as we see, only 500 or so are going to be matured and ovulated during the reproductive life of females. More than one begins the maturation process each month. But typically only one is ovulated or released, and the others are going to regress or degenerate. So only about 500 or so over the reproductive life of a female will actually be ovulated, yet 600,000 will begin to develop and degenerate by and large. So here we see a cross section through an ovary. This is going to be the cortex, this outer portion, and you can see a number of follicles in different stages of development, with the smallest follicles being represented by these small white points that you see. And then here's some of the larger follicles that we see represented here, filled with their fluid. Then this is going to be the remnants. After an ovulation, this is a corpus luteum. It's going to be one of the largest structures that we'll have in the ovary. And then here in the very center, this is going to be our medulla, the medullary portion of the ovary. Looking a little bit more closely, we can see our germinal epithelium at the surface. This almost looks columnar in nature, but we can call this high cuboidal. Then our stromal capsule, this is a tunica albuginea. And as we come down, now we're going to start getting into our follicles, our ovarian follicles of different stages. Here we can see one that consists of a central oogonia and some follicular cells surrounding it. Here we see a much larger oogonia that has begun the maturation process, and we have a number of layers of our follicular cells surrounding that oogonia. And we're going to use the number of cells and their histology to help us define what stage of development these follicles are progressing through. As you can see on the right, when we look at our ovarian follicles, we're going to start with a primordial follicle, an oocyte, and squamous, a single layer of squamous follicular cells. That's going to be the easiest to identify. And as the cell begins to develop each month under the influences of hormones, this is going to develop into a primary follicle. We're going to see the cells become quite cuboid in nature. Then we are going to have, this is a unilaminar primary follicle. And once we add on multiple layers, that's going to be a multilaminar primary follicle. And you can see this whole structure is getting larger and larger. Then we get to a secondary follicle when we begin to see the spaces filled with fluid present in our multiple layers of follicular cells. And then finally, our largest follicle, when we have this singular large fluid-filled space and our oogonia or oocyte surrounded by some cells detaches and becomes free-floating within this fluid, then we refer to that as a Graafian follicle. This is the mature follicle just before ovulation. So as we look at our follicular development, these are going to be some of the characteristics we're going to look at and describe to help us identify follicles at different stages. So the earliest is our primordial follicle. Here we're going to have our oocyte, this primary oogonia. It's about 25 microns in diameter. And this is going to be the one that's arrested in prophase 1 of meiosis. Here we are waiting for the maturation process to begin before we continue any further in development. And this oocyte is going to be surrounded by our single layer of squamous follicular cells. And this is the one we're going to be readily identifiable in those outer regions of the cortex. Here we have another diagram that sort of shows our follicular development. And here we are at our primordial follicle stage. We're going to develop those primordial follicles during late development. Here is birth, sexual maturity, and these primordial follicles again are held in place in that prophase 1, and then under the influence of hormones we'll begin that developmental process as we see here. Here we're looking in the outer cortex region for our primordial follicles, and as we look here we can see cells. We can see a fairly large nucleus of an oocyte. It's going to be a lot of heterochromatin. Most of the time you'll also see a dark nucleolus. But here, these cells are somewhat tall, but here's another one next door. You can see somewhat flattened, squamous in nature. All of these are going to be our primordial follicles. And these are going to be the most abundant that you'll see, again, out in that cortex region. Now, under the influence of hormones, this is going to change and develop. These cells are going to become taller, and you can see we're starting that process here as these become more cuboidal. But then these cuboidal cells may, in fact, reach columnar size, but we still have a single layer. But once we leave our squamous appearance and start to get cuboidal and even columnar, then we're moving to the next stages of follicular development. And that would be the unilaminar primary follicle. So we've got our primary oocyte, and you can see these cells are increasing in size. We've gone from 25 microns, possibly up to 150 microns in diameter. And the nucleus we call the germinal vesicle. You're going to see this very prominent structure inside the cytoplasm of the oocyte. Now, the single layer of follicular cells, these are going to be cuboid to columnar in nature, but they're still going to be a single layer as long as we're calling it unilaminar primary follicle. But we're also going to begin to see a zone or a band that appears between the oocyte and the follicular cells, and this is called the zona pellucida. Now, this is an acellular band. It's going to consist of molecules, and we're actually going to have microvilli from the surface of the oocytes, and we're going to have processes from our follicular cells that you can see here. We're beginning to term them granulosal cells. This is going to be a term that as the follicles develop, we will leave the follicular term behind and we'll begin to refer to these as granulosal cells that are surrounding the oocyte. So once again, we've got our primordial follicles here toward the top. Here we can see nice examples of a primary unilaminar follicle. Here we have our germinal vesicle, oocyte inside. Here we have our granulosal cells, single layer. And here you can see this bright band that appears. It almost looks like the surface of the oocyte, but it's actually going to be an acellular band of molecules that's going to exist. That is the zona pellucida. That's another indication we have moved into our unilaminar primary follicle stage of development. Now, as we continue to develop these follicular granulosal layers, we're going to add to them, so we'll have multiple layers of these. We're also going to continue to grow the cells surrounding the follicle, and these are going to begin to respond, and these are going to be our stromal cells. Now, the stromal cells closest to the follicle, we're going to call these the theca interna cells. These are going to be highly vascular, a lot of blood vessels. They're going to have a lot of luteinizing hormone receptors. And then we're going to have the theca externa cells, which are mostly going to look like those stromal connective tissue layers. So as we look at our multilaminar primary follicle, and I think you can easily recognize the multiple layers here of our granulosal cells. Here we have our oocyte, our germinal vesicle. Here we can distinctly see our zona pellucida situated between. And here we can see cells on the outside. These are our theca interna. They almost look glandular in nature because they are going to be secretory, and we'll see how those function later. But these are our theca interna, and then out here, our stromal type cells with collagen between. Those are our theca externa cells. So multilaminar primary follicle. Now, leaving the primary follicle, moving to a secondary follicle is dependent on the appearance of one thing. And this one thing are going to be these fluid-filled spaces between the granulosal cells. And these spaces can be multiple, but as they coalesce together and get larger and larger, they're going to coalesce into a single large cavity that we call the antrum. Now, these fluid-filled spaces are going to be produced by a material produced by the granulosal cells that are secreted, and this is going to be liquor folliculi is the term of this fluid that's filling these cavities. Now, this is going to continue to be produced, and this cavity, this antrum, is going to get larger and larger and larger. It's like filling a water balloon. And this is going to be the driving force that actually leads to ovulation. As we look at the next stage, our Graafian follicle stage, as this fluid continues to build and build and build, and now the oocyte is free floating within this fluid, you eventually get to the part that the Graafian follicle is as large as the ovary itself. There's no more room to grow. And so past this point, as the pressure builds, the pressure is going to rupture through the granulosal cells. Since we're now as large as the ovary itself, it's going to rupture through the capsule, the tunica albuginea, the germinal epithelium of the ovary, and that pressure of the fluid inside is going to project this free oocyte surrounded by its follicular cells, is going to propel it out into the body cavity and into the oviduct. That will be the process of ovulation, and it really is under the driving forces of this liquor folliculi. Now, once we begin to form these fluid-filled spaces, we are effectively separating the oocyte from the surrounding granulosal cells that were the follicular cells. And so the layer of granulosal cells adjacent to the zona pellucida, we call that the corona radiata. Then we're also going to have granulosal cells that surround the corona radiata and also for a time attach this unit, this oocyte corona radiata granulosal cell unit, attach it back to our granulosal or follicular cells that surround the antrum, and that bridge, that interconnecting bridge, is called the cumulus oophorus. So in our illustration, we can see that we've got our granulosal cells here, our multilaminar. We've got our oocyte, zona pellucida, surrounding it. Now we're beginning to get the liquor folliculi building up in these small spaces. Now, I don't like to call this an antrum because we have several of these, but I want you to understand as more and more of these form, and as this fluid pushes these cells apart, this is all going to coalesce into one large fluid-filled space. And that then is going to lead us to this Graafian follicle stage. This is the mature follicle. And again, it may be as large as the entire ovary, maybe 2.5 centimeters in diameter. So all of our follicular cells now are either going to be corona radiata cells, cumulus oophorus, or we call them membrana granulosal cells. They're going to define the boundary of our antrum. And I prefer to call the Graafian follicle stage, separate it from a secondary, when the oocyte, corona radiata, zona pellucida, cumulus oophorus cells, when those are free floating within the liquor folliculi. Now, some textbooks and some authors choose to do this differently. Some consider this to be a Graafian follicle stage, but to me, you still have a lot of interconnections here. This is still attached back to our zona granulosa or membrana granulosa here. Here we have our liquor folliculi filling a large space, but here we can see our oocyte, zona pellucida, corona radiata, the cumulus oophorus bridge attaching back, and here we have another. I still call this secondary follicle. Once this is free floating here in our liquor folliculi, that's when many textbooks agree, that is the defining characteristics then of a Graafian follicle, and we are then ready for ovulation to occur. Now, ovulation, this is going to be, again, under hormonal control and on a monthly cycle. So what's happening is the cells, the membrana granulosal cells, the theca interna cells, they are going to produce estrogen. Now, as more and more of these cells are formed, as you can imagine, more and more estrogen is going to be produced. So this is going to negatively feed back on follicle-stimulating hormone from the pituitary and shut that down. What else is going to happen is this increased estrogen is going to cause a massive surge of luteinizing hormone. Luteinizing hormone then is going to be the signal to really ramp up the production of liquor folliculi. That increased pressure is going to cause ovulation to occur. We're going to rupture through the follicle. We're going to rupture through the ovary itself. And also these hormones, luteinizing hormone, is going to cause that first meiotic division to be completed, and that oocyte then is going to be held at metaphase 2. So when ovulation occurs, the oocytes at metaphase 2, basically that's a female pronucleus. This is going to be jettisoned out and propelled out under the force of the liquor folliculi out into the abdominal cavity. However, the fimbria of the oviduct, the ampulla of the oviduct, that's going to be right adjacent to the ovary, and the majority of the time that ovulated follicular unit is going to be projected into the oviduct itself. Now, when this happens, because of all of the blood vessels that were present in the theca interna, there's quite a bit of bleeding. So blood is going to fill the cavity that remains left over from the liquor folliculi. And we're going to refer to this unit that's left over, the follicle that has ovulated. We're going to now refer to this as the corpus hemorrhagicum, because there's going to be hemorrhaging and blood is going to fill this space. That's going to be the immediate response to ovulation that's left in the ovary. Here we can see follicular development, again, starting with a primordial, going through multilaminar. We get a secondary with our liquor folliculi. We get into a Graafian when this is released. Here's ovulation. This is showing corpus hemorrhagicum with blood filling that, and then we'll go into the corpus luteum stage. But you can see what's happening to the thickness of the endometrium of the uterus, and we'll get to that a little bit later. but we can see the hormonal control that's happening. Here we can see follicle stimulating hormone is at its highest levels, and it starts to drop as estrogen levels from our granulosal cells begins to increase. This increase is going to immediately precede the increase in luteinizing hormone that leads to ovulation. Then we have the progesterone that's going to be produced, estrogen that's going to be produced. These hormones are produced by the corpus luteum. If fertilization and implantation does not occur at about this point, about a week it will take for that to occur, and the cells of the developing zygote begin to produce some hormones, then this is going to maintain this level, and that's going to maintain the level of the endometrium. So following ovulation, what we have remaining after the corpus hemorrhagicum in the blood has been removed, this is going to be by reabsorption by macrophages. We're going to then develop the corpus luteum. The granulosal and the thecal cells are going to continue to grow and develop. And in the confined space we have, these are going to become a highly folded structure, and this is what we refer to as the corpus luteum. And the two cell types that compose the corpus luteum are going to be our granulosal cells that remain, and we call them granulosal lutein cells, and these are going to be factories for the production of progesterone. And really the bulk of the corpus luteum that we see are going to be our granulosal lutein cells. But then we're also going to have our theca lutein cells, and these are our theca interna cells that remain. They're going to be producing progesterones principally, but then they're also going to be producing some estrogens and some androgens. But mostly the production of progesterone is going to be from our granulosal lutein cells. So here we have blood that remains from our corpus hemorrhagicum in the center of our corpus luteum, and here you can see the folded nature, and these are our granulosal lutein cells, the progesterone factories. And then on the outside we have some theca interna, theca lutein cells out here. You can see these. So these are going to be increased as well in nature, and they're producing the progesterones, but also estrogens and androgens. So that is our corpus luteum. So as we saw on the slide of the hormones and the effect on follicular development in the endometrium, here the progesterone principally and estrogen to a lesser effect, they inhibit luteinizing hormone and follicle stimulating hormone production. So they're going to inhibit the development of the next ovarian cycle. However, when you shut down luteinizing hormone, this is on a negative feedback as well. Without luteinizing hormone, the corpus luteum is going to begin to degrade, and you saw that decrease in the progesterone on that previous monthly chart. However, if pregnancy occurs, then human chorionic gonadotropin, that's the abbreviation HCG, that's going to be the target for many of the pregnancy tests that are done now. But human chorionic gonadotropin is going to maintain the corpus luteum. It is going to cause it to remain for 3 months. The corpus luteum then, in its production of progesterone, is going to inhibit the next menstrual cycle. So within 3 months, the corpus luteum is going to be totally worn out. It's spent. It is going to degrade after 3 months, but now the placenta is a large enough structure that it's going to take over the maintenance of the pregnancy and take over the inhibition of the next menstrual cycle. Now, following the corpus luteum, then we're going to have a corpus albicans. Albicans being white, and it's somewhat called that because it's basically going to be a scar tissue. This is where we get fibroblasts and macrophages coming in to remove a lot of the material, and what we have left over is, for all intents and purposes, going to be a scar that remains in the ovary. So here we see a corpus albicans. We can get a sense of the folded nature of the cells somewhat, but you mostly see stromal cells surrounding. You see collagenous tissue on the inside. That's the scar tissue. That then is our corpus albicans. Now, as we mentioned earlier, 500,000 follicles are going to develop. 600,000, I believe was the actual term, are going to develop. Only 500 are going to be ovulated. And so the remainder of these follicles that may develop up to the size of Graafian follicles are going to degenerate. They're not going to be ovulated. And so as these begin the process of degenerating, they're referred to as atretic follicles. And eventually this material is going to be removed by macrophages. It's going to be totally resorbed by the body. We're not going to have anything in the way of a corpus albicans or scarring to view at all. So here we see an atretic follicle. A lot of the granulosal cells are just very, very dark staining remnants of nuclei. These are called pycnotic nuclei. That's very characteristic of apoptotic cells or cells that are undergoing necrosis. We can also see the oocyte, and basically what we're seeing there, the oocyte looks dead for all intents and purposes, but the surrounding rim, the zona pellucida, still remains and is yet to be removed in that particular image. Here we see another. And again, what we're seeing are the very, very dark, tight staining nuclei. We can see the cells are even beginning to fall apart. We don't have that nice cuboid shape to them any longer. We're not really seeing the zona pellucida. So again, this is going to be an example of an atretic follicle in ovarian development. Now, the medulla, or the central portion of the ovary, fairly nondescript. This is going to be where we have our connective tissue. As you can imagine, a lot of elastic fibers in the cortex and medulla of the ovary, since we have to be able to flex with these growing Graafian follicles. But we're also going to have cells in the medulla that are called hilous cells. We're not going to identify them histologically, but understand that these epithelial types of cells in the medulla are going to function in a very similar way as what we will see in male reproductive system. We have cells that are called the interstitial cells of Leydig in the testes, and they produce androgens. That's also going to be the case for these hilous cells present in the medulla of the ovary. So now our oocyte corona radiata zona pellucida package has been ovulated, and now it is going to make its way into the oviduct, or the fallopian tubes. Now, as our ovaries were paired structures, so are our oviducts, and these are going to be divided into 4 distinct regions, not necessarily histologically, but just more locationally. We first are going to have the infundibulum. This is the opening portion of the ovary, and it's going to be surrounded on the edges by these finger-like projections. They're called fringes, and they're referred to as fimbria. Now, these fimbria are going to assist in increasing the surface area for this opening, almost acting like an assisting funnel to funnel the ovulated oocyte package into the infundibulum, or the opening, and into this next or expanded passageway of the oviduct that is called the ampulla. Now, the infundibulum is the opening. It's the opening of the ampulla, this very enlarged portion of the oviduct that is very near the ovary. And the ampulla of the fallopian tube is where fertilization must occur for implantation to happen at the right time. Now, this is important because the zygote, the fertilized egg, is going to need a couple of days to develop, and for those cells to expand so that you have a structure surrounding the developing individual. And this structure is called the syncytiotrophoblast. We'll get all of this next semester in human development. But the syncytiotrophoblast has to form. It has to be at a certain density of cells and function, so that when this package then hits the uterus, it can attach and implant itself. If fertilization were to happen in the ovary, then that package, that zygote, would simply be lost out of the uterus before the syncytiotrophoblast and this attachment complex would form, and so successful pregnancy wouldn't occur. So for successful pregnancy and implantation, fertilization must occur in the ampulla. Now, between the ampulla and the uterus, we have the bulk of the fallopian tube, which is referred to as the isthmus, sort of an interconnecting passageway. And then the smallest portion, just as we enter into the uterus, it's going to be surrounded by the myometrium. Actually, it's called the intramural portion, or the portion of the fallopian tube that is within the muscle of the uterus itself. So here we can see our diagram, and this is just for illustrative purposes and understanding. It's not exactly anatomically correct, as you can imagine. But here we have the opening. That is going to be the infundibulum, the opening. I don't like how they have drawn this, because the ampulla is actually this entire enlarged portion here at the end. Here you can see they've illustrated the fimbria, finger-like projections. There's the isthmus. And then the intramural portion is just this slight portion that has penetrated through the myometrium, the muscular layer of the uterus, before a fertilized zygote could enter into the uterus itself. As we look in the fallopian tube, we first look at the mucosa. Now, the mucosa is going to be highly folded. We've seen this quite a bit as we look at the folded nature of the esophagus, folded nature of the urethra and the ureter. This is going to be even more highly folded than we've seen there. This increases the surface area because we have a number of cells that are going to be critical to the function of the oviduct itself. Now, the cells are going to be simple columnar, and we're going to find the tallest in the infundibulum, and they get shorter as we get closer toward the uterus itself. But the two types of cells that we need to talk about are, first, cells are called the PEG cells. Now, as you can see, non-ciliated, that just tips you off that the other cell type we're going to talk about is the ciliated type. And these are quite interesting because these are going to be secretory cells in nature, and that's going to provide a nutritive and protective support for the spermatozoa. But really, the principal function of these PEG cells is to facilitate this process called capacitation. Now, spermatogenesis, as we're going to see in the next chapter and the final chapter for the course, this is the production from a spermatogonia into a mature spermatozoa, and one that can actually fertilize an egg. Well, the last step of the maturation phase actually happens in the female reproductive tract. And so these PEG cells are going to be critical for that and for delaying this process to an extent. And we'll see as we go through our discussion how capacitation actually works. But these PEG cells are critical for that process. Also, we're going to see that the PEG cells, part of their secretions that they produce, are going to be somewhat immunologically and immunogenically important because they're going to prevent infectious pathogens from accessing the ovary or the peritoneal cavity, because you can imagine the vagina and the uterus, they're open to the outside of the body, and so these secretions are going to be protective in that nature, protective to the mother herself. The ciliated cells, these are going to be the predominant ones that we'll see in a section of oviduct, and these are going to move in unison to propel material toward the uterus. The deeper layers, of course, we have the mucosa, submucosa, but the muscularis, we're going to have some smooth muscle, but it's really poorly defined in way of circular versus longitudinal layers. But we do have smooth muscle, and we will have some peristaltic type contractions that happen to help propel material through the oviduct. Then we will have a serosa on the outside. Remember, this is the connective tissue wrapped with a mesentery. So here we're going to have a simple squamous epithelium, the mesothelium, and the connective tissue portion of the serosa is going to be very highly vascularized as it is nourishing the cells of the oviduct. Here we see a cross section through the oviduct. We can see the muscularis labeled as M, smooth muscle. And again, it's very difficult to distinguish circular versus longitudinal. Here's our serosa on the outside, and here you can see the highly folded nature of the mucosa. It's almost very angular is how I like to look at that. So again, these are going to have our ciliated cells and our PEG cells on the surface. So here we have our columnar epithelium. Almost looks a little bit like what we would imagine in the intestine, if you can imagine this being a villi, and then we have our simple columnar cells. But again, we'll see the ciliated cells on the top. Remember, in the intestine, we're going to have microvilli. So we've got our ciliated cells that we see, and you can see the basal bodies of those here. But then these are interspersed with our PEG cells, our non-ciliated columnar cells. And that will be the tip-off then that we are looking in the oviduct. Now, in the uterus, this is a very muscular organ, and we're going to have certainly the myometrium portion, but then the endometrium portion that's going to enable for implantation to occur. And when we look at the uterus, we can divide it into three parts. We have the body of the uterus, which is the bulk of the middle portion, the fundus, which is going to be the superior rounded top portion of the uterus, and then the cervix is the narrow neck that it attaches down to the vaginal canal. So here in our illustration, the fundus is the superior portion, the body of the uterus where we have the attachments with our oviducts, and then we can see the cervix, the opening of the cervix being the os of the cervix interconnecting with the vaginal canal. Now, the inner lining of the uterus is going to be the endometrium. Now, the endometrium is going to be simple columnar in nature, and we're going to see non-ciliated secretory cells and ciliated cells, and this is going to be the layer that so drastically expands during the menstrual cycle of females, and this is by and large the portion that is going to be lost at menses each and every month in the form of that period cycle and the bleeding that happens. Now, in the endometrium, we have a lamina propria. This is going to be our dense, irregular, collagenous connective tissue. But it's within the lamina propria that we're going to have uterine glands. And these are our tubular branched glands that are going to extend all the way down to the myometrium. And these are going to be producing secretions that are going to assist in the nourishing of the zygote as it is implanting into the endometrium and prior to the formation of the placenta. As you can imagine, having a connection with the vaginal canal and the environment, we're going to have a lot of macrophages, leukocytes, reticular fiber stellate cells, these antigen-presenting cells, and these immune system cells are going to be present in the endometrium to protect it from any foreign pathogen. Now, the endometrium is going to have a deep basal layer. This is the layer that is kept. It is going to be regenerative, and it is going to reproduce the surface layer, which is called the functionalis, each month. So the functionalis is the thickest portion. It's the superficial layer on the surface, highly vascular, and this is going to lead to the bleeding that happens each and every menstrual cycle in females. As we can see in this illustration, we have the endometrium listed extending from the lumen of the uterus down to the myometrium, which is actually not illustrated here. We're just seeing the blood vessels. Here we see the functionalis layer and the basalis layer. Highly vascular arteries and veins. Many of these spiraling arteries are going to be present. And then here we see our uterine glands exhibited. And these uterine glands, as you can see, are going to dive all the way down to almost the myometrium. In this slide, this is a section through the uterus. We can see the myometrium, this reddish dense material at the bottom. This is going to be our endometrium. The functionalis is going to be closest to the myometrium, and the functionalis being at the surface. Histologically, you're not going to distinguish functionalis from basalis. It's all the same. But as you can see, all of the white spacing that you see in throughout here, these are going to be our uterine glands. Some of these are going to be some of our spiraling arteries and veins. At this magnification, it's difficult, however, for us to distinguish those. So the bulk of that white is going to be our uterine glandular material. Here we can see the lumen of some of our uterine glands and the columnar nature to the lining of our endometrium with the stromal cells situated between. This is just an example of the endometrium, and in these spaces between the highly folded nature, this is where implantation does occur in the endometrium. The myometrium is very thick, extremely thick, smooth muscle. I just can't express how thick it is. It's going to have the inner longitudinal, middle circular, and again, we've got a ton of blood vessels here. In this whole network of vessels we call the stratum vasculaire portion of the myometrium. And then we have the outer longitudinal. Now, typically, muscle cells do not actually increase in number. They increase in size. So it's not surprising that during pregnancy, these myometrial cells undergo hypertrophy. They get stronger. They get bigger. But they also undergo hyperplasia, and they produce more of the smooth muscle cells that will be critical for the process of parturition and childbirth. Now, this is just an image of different sections of smooth muscle. There's no way you could look at that and know you're looking at myometrium versus maybe smooth muscle of the digestive tract. It's just typical for what we see with smooth muscle. A lot of our characteristics that we know and have come accustomed to. This is just happens to be a section through the myometrium. Now, the uterus is going to be surrounded by serosa/adventitia, because much of the anterior superior portion, if you will, is going to be adventitia. That portion that's against the bladder itself is going to not necessarily have a mesentery that's immediately adjacent to it. But the fundus and the posterior part of the body, or in this case the dorsal part of the body, is going to be covered by a serosa. So it's partly serosa, partly adventitia. Now, the terminal portion of the uterus, the cervix, this is going to have epithelial cells that produce and secrete mucus. Now, this mucus is going to be serve different roles. First, the mucus is going to assist in the movement of the spermatozoa into the os of the cervix, out of the vaginal cavity, and into the uterus itself. However, during pregnancy, this mucus increases and thickens and becomes a plug that's going to plug the uterus to help protect the developing zygote and expanding uterus from any pathogenic attack that's coming from the outside. Now, the uterus, the external epithelium, is going to be stratified squamous non-keratinized. It's continuous with the same epithelium we see lining the vaginal cavity. And we're going to have a dense collagenous connective tissue that lies underneath. So that's not unlike what we see in the vaginal cavity or other areas where we've had our stratified squamous perikeratinized epithelium. In the cervix, we will have the cervical glands. These are going to be present, and also to assist, and as we've mentioned, the formation of the mucus plug, and to assist in building a bridge, if you will, of material that facilitates sperm entering into the cervix. Lastly, what we're going to see is that the cervix responds to a hormone. This hormone is produced by the lutein cells, and this is called relaxin. And so as we approach the end of pregnancy, as we get closer to parturition, this relaxin hormone is going to increase in its concentration. We will surpass a threshold, and this is going to lead to the dilation as well as the effacement of the cervix, the thinning of the cervix and the spreading of the os of the cervix as we approach parturition. So here we can see the transition point. We are going from our endometrial cells that you see at the top. The J represents the junction, and then here we have the cervix lining the outside. That's our perikeratinized, and it almost looks like skin. We can see our dermal and epidermal papillae, again, not unlike what we've seen in other areas where we've had perikeratinized epithelium. That is going to be the same histology that we'll see in the vaginal canal. So the vagina, this last portion of the female reproductive tract, fibromuscular tube. We have our three layers, the mucosal layer, again, as we've already described, stratified squamous perikeratinized epithelium. We're also going to have cells that produce glycogen. This is also going to nourish and support the passage of spermatozoa as they move throughout the region. But what we're also going to see is that when we release this glycogen, bacteria present, the normal bacterial fauna that we have in the vaginal cavity, this is going to use that glycogen to produce lactic acid, and this is going to be protective in nature because it keeps the vaginal microenvironment at a lower pH. That's not going to be a hospitable environment for many pathogens. So in that case, it's protective in nature as well. Lamina propria, loose fibroelastic connective tissue, will have a rich vascular supply going to the epithelium. The muscularis layer, again, we're going to have an outer longitudinal, inner circular, but we're also going to have a skeletal muscle portion to the muscularis, and this is going to be at the external opening, and this is going to represent the vaginal sphincter muscle that's present at the very opening of the vaginal canal. Lastly, we have our dense fibroelastic connective tissue. This is going to be our adventitia. Certainly, this is where we have a number of nerve endings coming from the pelvic nerves that innervate the tissue of the adventitia here. This is not unlike what we see of, again, most perikeratinized epithelium. Here we can see our cells on the right-hand side, very thick stratified layers, basal cells on the bottom. Then we have our typical adventitia, submucosa, muscularis, adventitia out here. So this is going to be fairly typical. And again, looking at this, you would be hard-pressed to determine if you're looking at the vagina versus looking at the cervix versus looking at the oral cavity. We have a number of blood vessels here. That might be one key point. We're not going to see that many blood vessels present in the oral cavity. Lastly, we have our external genitalia. This is going to consist of the labia majora, labia minora, and again, what we're going to see here is fairly reminiscent of what we've seen with integument. This is going to be skin. We'll have some adipose tissue, some layers of smooth muscle, but our labia majora are going to be the external surface. The outermost portion here is covered with coarse hair. The internal surface is going to be free of hair. However, sebaceous glands, sweat glands, we will see these on both surfaces of these outer portions of the labia majora. Now, this is probably one of the least pornographic images of female genitalia I could find on the internet, and I apologize for this being in Russian or some other language. But illustrated here, these are going to be the labia majora on the outside. Here we see the clitoris. This is going to be the labia minora. Again, most of the tissue we're looking at, and then here is the vaginal opening. The opening here is that of the urethra. So both of these labia majora and labia minora, again, are going to be the same histology as we see with integument. Now the labia minora, these are going to be just medial and deep to the labia majora. These are still going to be our stratified squamous keratinized epithelium, but no hair, no adipose tissue, but we will have sebaceous glands, blood vessels, and very dense amount of nerve endings in the labia minora versus the majora. Now, the space between the labia minora and actually covering over the opening of the vagina and the urethra, this is going to be called the vestibule, this common open area that we see present. So that's going to be the where the urinary tract empties and where the female reproductive tract opens into this one common area beneath and just deep to the labia minora. The clitoris, this is going to be at the more superior folds of the labia minora. We're going to consist of two erectile bodies. Now, this is not going to be unlike what we'll see in the male penis with our corpus cavernosa tissue, but also within this tissue, we're going to see a lot of nerve endings and receptors. We're going to have a lot of blood vessels that's going to help engorge the erectile bodies, but then we'll also have Meissner's and Pacinian corpuscles as portions within the dermal portions of the clitoris.